The problem is you do see a lot of antisocial people succeed. Loneliness is as big a risk factor for ill health and death.
We live inside our heads.
You go cold turkey, you go into withdrawal.
There is a lot of value in the stuff that we struggle with.
Better Thinking. Conversations with experts exploring all things psychology. Welcome back to Better Thinking. My name's Nesh Nikolic, and today I have the great privilege of speaking with Dr Joanna Moncrieff, a distinguished psychiatrist, academic, and author of several influential books, including her latest title, Chemically Imbalanced: The Making and Unmaking of the Serotonin Myth. Dr. Moncrieff's pioneering work challenges conventional psychiatric narratives, particularly the widely held belief that psychiatric drugs correct a chemical imbalance in the brain. In this episode, Joanna delves into the serotonin theory of depression, the evidence or lack thereof for a disease model of depression, and her view that depression is often a natural response to challenging life circumstances. We also explore the limitations of measuring serotonin to support the chemical imbalance hypothesis, the role of the placebo effect, the potentially disempowering impact of the serotonin narrative, and the critical importance of informed consent in mental health support for people. As a key figure in the critical psychiatry network, Dr. Moncrieff has been instrumental in questioning the medicalisation of mental distress and the pharmaceutical industry's influence on psychiatric care. This conversation with Joanna was incredibly thought-provoking, and I'm excited to share it with you. But before I do so, let me first provide a disclaimer statement. As a psychologist, I provide this podcast for informational and educational purposes to foster discussion and critical thinking about mental health topics. The content of this podcast, including the views and opinions expressed by myself and Joanna, represents one viewpoint and is not intended to serve as professional psychological or medical advice, diagnosis, or treatment. Research in mental health encompasses many sides, views, and limitations, and is therefore open to debate. Constructive debate conducted in good faith is a hallmark of scientific method, encouraging rigorous exploration of ideas. Listeners should seek guidance from qualified healthcare professionals for personalised advice regarding their mental health, medical conditions, and treatment. I strive to adhere to AHPRA guidelines and ethical practice, ensuring that discussions are informed and respectful of diverse viewpoints. Listeners are encouraged to approach the topics discussed with an open mind and consult with appropriately qualified professionals as needed. Any concerns about the content should be addressed through constructive dialogue. I really hope you enjoy this episode. Joanna, a big thank you for coming onto the show today. This is an interview that I have been waiting for some time. You probably don't know, or you certainly don't know, how influential your work has been in my work as a clinical psychologist, and also just thinking about psychiatric drugs and how they can be used, and some of that nuanced world around that. Not that I am a practicing psychiatrist or anything of that nature. I don't have that training, but it's a great pleasure to be able to talk to you today.
Thank you for inviting me, and really nice to meet you, Nesh.
Look, I'd love to start with this new book that you've written, Chemically Imbalanced. I know that it's only come out this year, and I do have to confess it's not something that I've read yet, but I'm eagerly looking forward to. But maybe we can start with that book, how that's come about.
Absolutely, yeah. So it's called Chemically Imbalanced, and I wrote it as a response to the response that we got when that is myself and a team of colleagues, published a paper on the evidence for the serotonin theory of depression. So I had been wanting to do this for a while because I'd been wanting to look at this evidence for a while because I was aware that most people in the know, most academics, most researchers knew that the evidence linking serotonin and depression was pretty poor, but no one had really sort of got that evidence together so that, sort of a conclusion could be drawn about it. So I had the idea of getting some colleagues together, looking at all the different areas of research that have taken place over the last few decades that have investigated links between serotonin and depression, and putting all that together. And in a nutshell, we found that none of the main areas of research provide consistent or convincing evidence that there is any sort of association between serotonin and depression, let alone for this idea that depression is caused by a deficiency of serotonin, the so-called serotonin theory of depression. And so we published that in the summer of 2022. It got massive media coverage because people had come to believe that the idea that depression was caused by low serotonin was not just a theory, it was an established scientific fact. So people were really shocked to find out that it wasn't. And of course, many of those people were people who were taking antidepressants and who had made their decision to take antidepressants on the basis of being told, you have something wrong with your brain. Here is a drug that's going to correct it, that's going to put it right. If you're told that, then of course it makes sense to take the drug. If you're told that actually we've no idea what's going on in your brain and no idea how this drug is going to interact with what's going on in your brain, then it's a very different situation. So the paper caused great interest and surprise and shock among the general public and the media. But the reaction that was very interesting was the reaction from my profession. So quite a lot of psychiatrists seemed to want to brush our findings under the carpet. In fact, it seemed that they were really quite angry that we'd looked at this area or chosen to publish anything on it. And they wanted the public to continue to believe the idea that there is some link between some sort of biological mechanism in the brain and depression, even though one of the most common and popular hypotheses for the nature of that mechanism, it turns out, is not supported by evidence. So that reaction really shocked me. It wasn't everyone. There were psychiatrists who were open-minded and prepared to discuss the evidence, but it was certainly quite a lot of psychiatrists, certainly a lot of those that were in the public realm were really pushing back. And it seemed to me, as I said, that they didn't want the public really to discuss or consider the implications of our paper, of our research. So that's why, what motivated me to write the book, because I thought actually this information does really need to be out there for people so that they can make up their own minds. And it's also important that people realize that there are some professionals out there, some doctors out there who don't want them to hear this for various reasons that are not to do with the science.
Now, this theory is still very strong, certainly here in Australia. I hear it still commonly from clients saying that the that there's a chemical imbalance, that they need some serotonin increased in their brain. It's been described like that from various health professionals, lots of readings themselves. So it's not just coming from GPs and the like, psychiatrists. What is it about this that makes it so sticky? There are there's two opposing viewpoints. There is a viewpoint saying, oh, the science is in and antidepressants have value. They work on an SSRI model that therefore says that there is a deficiency, and that deficiency is being I suppose modulated by the intake of these drugs. You're suggesting there's something different. There's a different mechanism going on, and that theory is shouldn't be taken blindly.
Well, I'm suggesting that there's a different way of understanding depression, and in fact, what I'm suggesting is that the alternative way of understanding depression, which I suppose you could just broadly summarize as depression, is a natural human reaction to things going wrong in your life, to bad things happening to you and bad circumstances. That it's one of a range of emotional reactions that we have, and these are part and parcel of what it means to be an intelligent organism that responds to one's environment. Now, that way of understanding depression was how people used to understand it. So there was some very interesting market research done at the beginning of the 1990s as part of a campaign, a disease awareness campaign, to encourage people to see depression as a medical condition and go to your doctor and ask for treatment. I wonder who sponsored that campaign. Well, it was partly sponsored by Eli Lilly, the makers of Prozac. Now, this market research found that at that time, the idea that depression was a brain problem or due to a chemical mechanism or any other sort of brain mechanism was not widely held. Most people thought that depression was caused by divorce, unemployment, child abuse, things like that. And most people thought that taking a drug to deal with emotional problems like depression was not a good idea. And the pharmaceutical industry, it seems to me, set out very deliberately at that time to overturn that underlying understanding that we had about the nature of depression and to replace it with the idea that depression is a medical condition, that it is caused by some sort of underlying biological mechanism, maybe a chemical imbalance, maybe something else, that can be rectified by a drug. So there are those two different ways of looking at it. And interestingly, some leading psychiatrists, including Ronald Pease, who's a leading American psychiatrist, and Wayne Gorman, who used to work for the FDA in the States, have both said that the idea that depression is a chemical imbalance is a metaphor, i.e. it's not real, we haven't really found a chemical imbalance. But what they've said is it doesn't matter that it's a metaphor because it must be true that depression is due to some biological mechanism. I'm paraphrasing them now, they haven't said this exactly, but the implication of what they're saying, the implication of saying that it doesn't matter that it's a metaphor, is that they assume that depression must be caused by some underlying biological mechanism. Therefore, it really doesn't matter what we tell people, because this will turn out to be the truth. The trouble is, it hasn't turned out to be the truth. There is no convincing evidence to support the serotonin hypothesis of depression. There are many other hypotheses about, theories about possible biological mechanisms that might underpin depression, but they haven't been demonstrated either. And the evidence base for theories like the idea that depression is due to abnormalities in the inflammatory system, for example, that's a current alternative to the serotonin hypothesis, or that it's to do with abnormalities in the neuroplasticity or the generation of new nerve cells or new nerve cell projections. These have a far weaker evidence base than the serotonin theory has. So it's not likely that those are going to turn up with to be solid scientific findings either.
What is the evidence for the serotonin hypothesis?
So people have looked at a number of things. People have tried to so first of all, to say you can't directly measure serotonin in the brain and in human beings for obvious reasons. If you start sticking things in the brain, it's really not very good for people. So various indirect measures have been taken. So people have measured serotonin in the blood, for example. People have measured serotonin, or actually more usually its metabolite, because serotonin is pretty unstable. So usually they look at the metabolite of it in the cerebrospinal fluid. So that's the fluid that is in the cavity surrounding the brain. So that's probably the closest you get to a measure of serotonin in the brain. And the research on that shows the research on serotonin in the blood shows no connection between the people with depression do not have lower levels of serotonin in their blood than people without depression. But actually, interestingly, what it also showed is that people who are taking antidepressants long term do have lower levels of serotonin in the blood, regardless of whether or not they have depression. So even though we're told that antidepressants increase serotonin, and they probably do temporarily, it may be that in the long term they actually reduce it. Because we don't have evidence that actually there's anything going wrong with your serotonin when you're depressed. It's difficult to know what consequences that will have, but and because we don't understand much about the functions of serotonin, it's difficult to know quite what the implications of chemically manipulating the serotonin system are. But just to say, we don't even quite understand what effect antidepressants are having on serotonin. And the research on the serotonin metabolite in the cerebrospinal fluid did not show an association with depression. People have looked at serotonin receptors. They've looked at the transporter protein that transports serotonin out of the nerve synapse. That's the gap between the nerve cells where it has its action. So effectively deactivates the serotonin. And SSRI antidepressants are one of their effects is to inhibit the serotonin transporter protein so that more serotonin is available in the synapse. That's the theory anyway. So people have looked at the serotonin transporter protein, they've looked at serotonin receptors. Those have not shown consistent evidence that there is a deficiency of serotonin either. Then people have looked at genes for the serotonin transporter protein. Now that area of evidence was interesting because some of the earlier studies suggested that there might be links between the gene for the serotonin transporter and depression. Then more studies were done and didn't really look like that stood up. But then someone proposed that a group from the States proposed that it wasn't just a straightforward link between the gene and depression. It was an interaction between the gene, having the gene, being a victim of abuse or maltreatment during childhood, and then getting depression. So there were a lot of studies to look at the possible interaction between the gene for the serotonin transporter and childhood abuse or maltreatment and subsequent depression. Again, some of those early studies seem to suggest maybe there was a link, maybe there was this interaction going on. But actually, as the studies got bigger and better, that effect disappeared. And there have been two very large, very convincing, good quality studies conducted recently that have shown absolutely no link between the serotonin transporter gene and depression, and no interaction effect either. But what they did show is a very strong association between being a victim of abuse or maltreatment in childhood and getting depression subsequently. So supporting that alternative way of understanding depression as an understandable reaction to bad things that have gone on in your life in the past or that are going on in the present. And then finally, there is a set of experiments that have tried to see whether lowering serotonin levels in the brain indirectly by depriving the brain of one of the proteins that is used to make serotonin can induce depression in volunteers, in people who are not already depressed. And those studies basically show very convincingly that you cannot make volunteers depressed by doing this, by tweaking this amino acid in the diet. There were some studies that appeared to show that maybe you could make people who were already depressed, many of whom had used medication, depressed again by using this manipulation. But actually, those studies are quite old, quite small, very inconsistent. And when we looked at more modern studies, they didn't replicate that finding. So there you are. None of the sort of recent areas of research really show any convincing evidence. Since we published that review, a very small study came out that claimed to provide more direct evidence of serotonin abnormality in the brain. In fact, this was highly indirect evidence. what it consisted of. It was a study giving people amphetamine and looking at the amount of serotonin that is released in response to amphetamine. Quite a few of the participants in that study had Parkinson's disease, which we know affects the serotonin system as well as other neurochemical systems. So you would expect there to be some abnormality in them, in that group of people anyway. And anyway, the result they found was really not convincing. It was only just about statistically significant with a one-sided test. You know that we should be using two-sided statistical tests. And the result also wasn't robust to outliers. So I don't think that, that's a new area of research, but certainly nothing has been proven in that area either.
It seems for me that first point that you made around depression being a natural human reaction, to whether it's bad conditions, bad things happening, loss of purpose and meaning and drive. They're very, very common things that most of us in our lifetime will experience, whether it's at that clinical level or not. It doesn't matter. It's still a depressed state, feeling flat and low and losing energy and potentially having difficulties with some function, maybe even withdrawal and so on. That's a very different model to suggesting that depression is based on a biological problem, that there's a disease going on, or there's something that needs to be fixed. Can you talk me through that a little bit, that sort of differentiation between a disease model of depression versus a natural human response, and I suppose that drug-centered.
Well, I think this is where the question of whether there is evidence for an underlying biological mechanism is key, because, like you say, we are familiar with what it feels. Most people are familiar with what it feels like to feel at least somewhat depressed. And quite a lot of people, go through periods when they're quite significantly depressed. And of course, some people will have more severe episodes of depression. We're all different. We all have different vulnerabilities and respond differently to the same sorts of situations. But nevertheless, we can all recognize what it means to be depressed. We can all understand the sort of reactions that it involves. And of course, when we have feelings of depression, also when we have feelings of excitement or anger or elation or everything else, there are things going on in our brain. I am not suggesting that that somehow what we experience is disconnected from our biological selves. So there are changes happening in the brain. But in order to think of this as a medical condition in the way that we think of most medical conditions, in the way that we think of them as having a physical origin, a direct physical cause, we really need evidence that there is a mechanism, a specific mechanism that drives these feelings when they get severe, and that can differentiate the more severe feelings from ordinary cases of sadness or despondency or whatever. And unless we have evidence of that, I think we have to assume that all these cases, however severe it is, are understandable reactions to the circumstances that people find themselves in, as I think people naturally tend to do if they are not persuaded otherwise by promotional campaigns organized by the pharmaceutical industry and their supporters. I suppose what I'm trying to say is, I think if people are going to suggest that depression is a disease, is caused by a specific biological mechanism, the onus is on them to prove that. The onus is not on us to disprove it, because we have a perfectly good explanation for depression. It is an emotional reaction to circumstances. That doesn't mean that everyone can immediately identify what the circumstances are. I think people can be depressed and not understand why they're depressed. In fact, I think that's quite common because, of course, if you're feeling depressed, you're not thinking very clearly. And that's one of the functions of therapy or any sort of support and help for people who are unhappy or depressed. It's helping people to try and identify what the actual underlying problem is, as a first step to then identifying what might be able to be done about it.
It is interesting, as you say, that difference between that disease model, because in psychology, we are very much, if we look at our interventions, we're very much looking at it as a natural human reaction. That's kind of what we lean into, whether it's behavior activation, whether it's changing one's perspective through CBT, ACT, schema therapy, etc. We solely work on what the individual can do themselves. And part of that is also to query and question the decisions they make in their environment, whether their environment is conducive to well-being or if it's quite depressing, and many people in the modern world can feel quite depressed by their circumstances, the choices that they make and the like. And I'm certainly not saying that it's saying this in a non-compassionate way that someone can just change their circumstances. A lot of us have great responsibilities, and that's part of what can tie us down and make us feel terrible. So that natural human reaction has always resonated for me, and hence why your work has spoken to me, rather than saying where is the disease. That model between is grief depression or is grief, and how we look at that, and we change the categories to accommodate for that loss, not necessarily being a disease, but
Yeah.
potentially.
I think this is such an important point, and I just wanted to mention that there are several research studies showing that if you tell people who are depressed or anxious that they have a chemical imbalance, they are more likely to think that they will not recover and less likely to think that they'll be able to help themselves. And there's some evidence that actually they have worse outcomes. So, I think giving people this idea that depression is a medical disease, it puts it beyond their control. And of course, you can understand how if people are feeling really desperate and distressed, initially it might be a relief to think, oh gosh, it's not my fault. This is something that the doctor can take care of. So, I think temporarily in the short term, there can be an appeal to that. But in the long term, I think it's profoundly disempowering and unhelpful to people to be led to believe that their problems are down to some brain chemical abnormality or some other brain mechanism that is beyond their control and that they need to take medical treatment to address. And of course you can see how it's that message, even though most doctors nowadays will they won't just tell people to take antidepressants, they will also encourage people to have therapy or go and do activities, try and address problems in their lives. But of course, if you're telling people on the one hand that they've got a brain problem, on the other hand that they ought to sort out their lives, those are two quite contradictory messages. And I think that's very confusing to people as well. If this genuinely is a brain problem, I mean, if you were depressed because you had a thyroid disease, you wouldn't go and get therapy. You would treat your thyroid disease. So telling people that they have a disease and we've got this drug treatment for it does not encourage people to try and explore what the problem really is and to try and find their own ways to address it, which is not to say that not lots of people thankfully do find their way to doing that. But there are some people who are going to be put off doing that, or even if they do make some changes in their lives, they will always, I think, lack confidence and not realize necessarily that it's the things that they have done that have helped them rather than the pill that they have taken.
There's a real concern as a psychologist about, one's locus of control. And if we're reinforcing, this external locus of control as being the moderating factor, it becomes disempowering, as you say, and that itself can make someone feel hopeless, helpless to the situation, versus an empowering model and saying, maybe it's just appropriate to say we don't know, rather than say we do know. That the evidence is still not there, or there is, many different evidences that are being proposed. And so the verdict's not out yet. We're still trying to work through that. In the meantime, what are the things that we can do?
Yeah, I think but I do think it's important that that is said explicitly, because, at the moment, as you were saying, most people have been persuaded and continue to believe that it's been scientifically established that depression is a brain problem, that there's some brain abnormality. So I think it's very important to inform people that that is not the case, that idea is misleading propaganda, and that, we don't know. We have not found an underlying mechanism. We don't know what's going on. It may be that in the future we will find some physical process underpinning depression, but it may well be that we won't, because we have been trying to do this for a long time and we've not found it so far. So my hunch would be we're not going to find it. We're barking up the wrong tree. That's the wrong way of looking at the problem.
Can I ask you about the use of antidepressants? I know it's important to have a nuance and a conversation around antidepressants still being able to be used, or there being potential efficacy. How something is used is an important question. And I know, for example, having spoken with Dr. Mark Horowitz, about some of the challenges with antidepressants as well when someone decides to come off, and his own personal experiences in that. There's still a place for supporting people with different forms of drugs who are going through depression, even though we don't have a specific biological marker that we can point to. It's still appropriate to consider drugs as a form of intervention. Is that right?
Yeah. So let me just try and summarize quickly.
Please.
My views on what antidepressants are, what they do, and how useful they are. So drugs like antidepressants are drugs that enter the brain and change the normal state of our brain chemistry and brain activity. And that has consequences for our mental state. If you change around what's happening in the brain, the chemistry of the brain, you will affect our level of consciousness, our thinking processes, and our emotions, as you do if you drink alcohol, smoke a cigarette, or have any other sort of psychoactive drug. So my view is that the effects that people experience when they take antidepressants are the consequences of the way that antidepressants change our normal brain chemistry and our normal inverted commas, because of course, there is no normal, but our baseline state, the baseline state of brain chemistry and mental activity. Now, all drugs change the brain in different ways and therefore have different consequences for our mental states. So I am not saying that antidepressants are exactly the same as alcohol, for example. They have different sorts of effects on our brain chemistry and different sorts of effects on our mental states. But they do change our mental states in more or less subtle ways. Now, one of the reasons that people have not appreciated this fact about antidepressants, and there's no denying this fact, there's no denying that they enter the brain and change the normal state of the brain, whether or not they also target some underlying mechanism, although that's not been shown. But the reason that no one's really talked about this it is because of this idea that what they're doing is targeting an underlying mechanism, but also because we think of drugs that change our brain chemistry and change our mental state. We think of psychoactive drugs as having nice, pleasant effects that people want to experience, like alcohol, like cannabis, or some people want to experience, because I should emphasize that actually there's a great variety in the experiences people have and in people's reactions to the experiences. So not everyone enjoys the effects of alcohol, not everyone enjoys the effects of cannabis. So of course there's great variety, but some people do. And we have had great difficulty understanding that actually there are some drugs that can change our brain chemistry, change our mental states, but actually overall the effects are either not that nice or really quite frankly quite unpleasant. And antidepressants, first of all, the changes that some antidepressants produce are quite subtle, but secondly, the changes are not generally experienced as being very pleasant, which is counterintuitive, seems a bit weird. But they make most people feel a bit groggy. Most antidepressants, they come from lots of different chemical classes, they're all different, but most antidepressants make people feel a bit groggy, a bit blurry, not very pleasant to take. But one effect that they do have is they seem to numb emotions to some degree. So they reduce the intensity of positive and negative emotions. And of course, in theory, you can see how that might be useful for someone who's, acutely distressed, feeling very anxious or very down. Some people seem to say that, that effect is useful and they like that effect. They value that effect, not that they like it particularly, but they value that effect. Other people find it quite unpleasant and unnerving. But in theory, that is a reason why antidepressants might be perceived as being useful for people. The trouble is, I'm not convinced it is useful, because the clinical trials that have looked at whether antidepressants are useful or not really seem to show that they are barely different from taking a placebo. The difference between taking an antidepressant and taking a placebo in these trials is very small. It's 2 points on a 52-point rating scale. No measure of the clinical significance of an effect suggests that 2-point difference is clinically significant, or even detectable, even noticeable by people themselves or by people observing other people. And I think there's another explanation for that difference over and above the fact that these drugs are causing this emotional numbing, and that is that that people in these clinical trials are probably, in some of them anyway, are probably experiencing what we might call an amplified placebo effect. That is, the people who are taking the antidepressant, many of them can guess that they're getting the real drug rather than the dummy tablet, and therefore they don't just get a placebo effect, they get an enhanced placebo effect. They can guess because they get some side effects or just because they feel a bit different. And we know that if people guess they're taking the real drug, they do much better than if they guess they're getting the dummy tablet. And so I think it's very likely that small difference is actually a reflection of an amplified placebo effect rather than any pharmacological effect, whether that's the emotional numbing they cause or some hypothetical action on some underlying mechanism. So in principle, I agree with you that sometimes that in theory drugs can be useful in some situations. And I've also done quite a lot of research on antipsychotic drugs, and I do believe that antipsychotic drugs can be useful in reducing the intensity of psychotic symptoms when people are acutely psychotic, for example. I'm just not convinced that antidepressants really are useful for people, even when they're really distressed. Because although they have this emotional numbing effect, it really seems as if their effect is largely a placebo effect. I'm aware that, people taking antidepressants, might find that sort of offensive to, for it to be suggested that they're just, responding to, they're gullible, they're just responding to a placebo. So I'd just like to emphasize that a placebo effect is about expectation, but also hope. Of course, when people are given a tablet and told this is going to make you better, of course people are going to feel better. They've got some hope. Someone said, we're going to help you. Things are going to be okay. And that's why I think, so many people do feel they've been helped by antidepressants. The trouble is that if that's a false hope, if it's actually not the pill that's doing the job, but the offer of support, then we need to understand that, because then people are going to unrealistically invest their hopes in a pill rather than looking to the other things that we've been talking about that they might be able to do to help themselves and address their situations.
Well, there's always part of my passion within the ACT framework is looking at context and unwanted, secondary gains and all that stuff that goes on. I don't think anyone is offended by the placebo effect, but I think we can then make an inference that can then create, offensiveness. At the same time, going back to the locus of control question is if there is, even if there is an immediate state-based, improvement, for example, if I'm feeling flat and I have a little bit of alcohol, if we call that alcohol medicine, there's an inference there saying, I need the medicine to make me feel better. And so it goes out and says, there's something wrong with me, and the medicine is fixing me, and therefore I need more of the medicine. And even the language medicine is different to the language of drug.
Yes.
And so, language, I think, is so important, and the nuance of conversations is so important to really listen and to really think. And this is why I'm always nervous talking about these types of things. If I can just call out the elephant in the room, a lot of this is frightening. It's concerning. Will there be some type of backlash? Because we don't all hear the message in the same way. That we make these inferences and we kind of get caught up in it, and this is why there's always caveats throughout all of my podcasts. And here we're doing it again, trying to say, I'm not saying this, I am saying that, and we're trying to be really thoughtful, because it's an important and delicate conversation, trying to say what's the evidence, or at least what's the strongest correlations that we currently have, that we should consider, because none of these are a direct causative. Theories are useful, but then they need to be scrutinized with great consideration, rather than saying this is correct, so therefore we'll push it and we'll just find evidence for it, because you can do that. Science allows you to. I think people have said, at least in academia, if you threaten the data for long enough, it'll tell you anything, something like that.
Yes. Yeah. No, that's right. I mean, I agree with everything you said, and I think it's just worth drawing out that point about, if you have a drink, and it makes you feel better temporarily, we all recognize that. We all recognize that telling someone to just have a drink every day because that's going to make them feel better is not a good response to depression. Might be okay as a temporary fix, going out and having a drink with your friends actually might be quite a good thing to do. But, just to use alcohol to numb the pain every day is not a good response. And yet, essentially, that is what we're doing when we give people antidepressants. As I've said, by saying that, I'm not saying that the effects of antidepressants are exactly the same as alcohol. They're not. But we are giving people something that does change their mental state, probably numbs their emotions to some degree. And and that is going to have consequences, some similar consequences to if you were actually, telling someone to go and drown their feelings with alcohol every day. And so some of those consequences are psychological, as we've discussed, not therefore exploring other ways of addressing their negative feelings and looking at their circumstances and, trying to understand the source of their feelings and how they can be addressed. But some of the consequences are physical consequences. If you adjust your brain every day with a chemical that it's not used to, it will respond, it will change, it will try and counteract the effects of that drug. It may also be damaged in some way. The drug may damage the brain. And the adaptation is what leads to dependence and people having difficulty with withdrawal symptoms. And the fact that some people have really severe and protracted withdrawal symptoms, and the fact that some people experience persistent problems with their sexual functioning and persistent emotional numbing after stopping antidepressants suggests that possibly the drugs have done some damage as well. So, they've caused some, hopefully not permanent, because I think most people do recover at least a good extent from these conditions, but cause some lasting changes that have negative effects on people's feelings and behaviors.
It does point to, though, that numbing psychoactive response, where a lot of people, certainly in my clinical experience, have spoken about their libido changing, and that being one of the reasons why they're considering whether to maintain. They're balancing the effect, or the wanted effect against the unwanted effect, and for many have decided to continue, many have decided not to continue, but the conversation's important rather than saying yes, because people can still make a decision, right? It's not up to anyone to go out and say you should or shouldn't. This is about informed consent and being aware of the whole picture, not blindly being told this is a theory and the theory is true. We need to understand what the word theory is and examine it. No different to, there's a theory which says that behavioral activation has utility for someone who's feeling depressed, that going out and leaving your bedroom and engaging with others, socialization is useful, having routine and food and sunlight and just being physically out. There's many components. We can talk about that all day. They are also based in theory, and then we do research to go and say with controls and so on, but they're not going out and saying this is biological and the exercise is changing something that's inherently wrong. So your body will respond to exercise, and it will produce a different psychoactive substances in your brain. Like even food does it. I know if I eat terribly, my mood can go down because I just feel awful. When you feel sick, you feel awful. Thankfully, it's all short-lived. These are those, I suppose, what you're talking about, the state change rather than a biological change.
Yes, absolutely. I just wanted to pick up on something that you said earlier. Now I've forgotten what it was. Yes. So informed consent, super important. And I just wanted to say that yes, I think this is the heart of the issue. People need to be able to make properly informed decisions about whether or not they want to start taking antidepressants, and if they have started, whether they want to continue taking them or think about coming off them. And in order to do that, they need good information on all the likely and probable, likely and possible side effects and complications of taking them. And one very common one, as you mentioned, is sexual dysfunction. So I think that's really important for people to know about. It's been widely recognized that antidepressants cause sexual dysfunction while people are taking the drug. But what has not been widely recognized until recently is that some people have persistent effects when they stop the drug. And it seems to me that's extremely important for people to know, especially young people who are contemplating going on antidepressants. We don't know an awful lot about this persistent sexual dysfunction, but it has been shown in animal studies. So it's very unlikely that it's just a feature of people's depression coming back. It seems to be specific to antidepressants rather than other sorts of drugs that are prescribed for mental health problems. It's associated with persistent emotional numbing in many people. And it may be that it's not that uncommon. There's been a survey done recently suggesting that 10%, over 10%, 13% of people report some sexual dysfunction persisting after they've stopped antidepressants. So this is a very, very important thing for people to know about if they're going to give informed consent to starting or continuing on antidepressants. And then your points about about how we can help our mood, I think, are really important as well. When people ask me, okay, how would you treat someone with depression? I think there are a number of things I'd like to say. First of all, to start off with, we're not treating depression. It's not a thing, and that's one of the ways that we've gone wrong. It's not a thing that people have, like they have tuberculosis or pneumonia or cancer. It is a way that people respond to the world. Therefore, each individual with depression is different. They're responding to a different set of circumstances. They need different sorts of help and support. So some people may need relationship counselling. Some people may need support with things going on at work. Some people may need therapy to try and help them work out what they're reacting to in the first place. But there are also some general things that people can do to help improve their mood, including exercise. That's consistently been shown to help people's mood and to help with anxiety and with sleep. Various forms of meditation and relaxation have also been shown to be helpful in depression. And then there are things that don't have quite the same level of evidence base, but are probably also helpful, like having a good diet, trying to keep fit and health, trying to stay healthy, socializing, finding a purpose in life. As you said, I think that's very important. Feeling that you're contributing to the community in some way, and that that you're helping other people, having good relationships. All these sorts of things, I think, are important to address.
Thank you so much also for pointing out this language, because I unknowingly, and it's just dawned on me, am doing this. The phrase of treating depression. What an incredible way that it's come into my language set, because that infers the disease model. There's something to be treated rather than understanding. Depression being a natural response, and I think that in and of itself is a ginormous leap or insight, at least for me, of saying, got to watch my language. I've got to think more thoughtfully about this, because this continues to reinforce my own thought process. Unknowingly, just becomes repetitive. It's like a large language model. You just spit out the next word that's supposed to, follow in the sequence. And I think you're right. We shouldn't be treating depression. We need a new language set of, supporting people who are naturally responding with the right emotional reaction to their conditions, and let's examine that, be thoughtful, compassionate, considerate, and assist from that level. And that doesn't suggest that people aren't going through the experience of feeling depressed. That's a very real thing. We just trying to ask, what's the origin of it, and is the origin a disease? But we can't point to it. We don't know where it lives. There are some clues, but these are correlations. Correlations aren't causation. So we create theories, and if we bolster one theory, it becomes kind of concerning, versus giving the same weight or time to discussing other ways of, how depression shows up as a human experience, or why.
Yeah, I think that's such a good point. Our language has just become saturated with these medical terms. We talk about having depression. We talk about a diagnosis, depression as a diagnosis, diagnosing depression, having depression, treating depression. We talk about people as patients. We talk about treatment. And all this, as you say, reinforces this notion that depression is a disease, it's a medical condition, it's not something that people can manage on their own. They need, interventions on their body, on their brain, in order to be able to manage it.
And interestingly, if I go back to another thing that you said, is that around informed consent. My apologies, jumping back a little bit, but what's interesting is when we look at a psychoactive drug model of, I'm going to provide something to you, an antidepressant or whatever it might be, I don't imagine that part of the prescribing model says go through all the unwanted negative effects, so the side effects that we might call them, because that primes someone to monitor it. And we know that expectation of, let's say, a reduction in libido is unwanted. So we don't go out and say, I'm going to give you some medication. Well, I can't speak for doctors and psychiatrists but I imagine just generally, we don't go and say this can, go out and give you weight gain, or this can go out and, or maybe we do with that because that's a common one, but, libido or other unwanted effects, because we don't want that to happen. Yet we know that's a moderator. The placebo is a moderator. So but informed consent, it's important that we provide both sides, because if we are saying there is science behind this and that it can happen, it's measurable, it does happen in X amount of people, we should know what we're taking and why.
I've just been, I was on an FDA panel discussing the risks of using antidepressants in pregnancy last week. And so I've been thinking about that a lot recently, and the importance of informed consent in the context of pregnancy. So the importance of women knowing the possible negative effects, and there's debate about them, but there's, certainly evidence that antidepressants can have all sorts of harmful effects on the pregnant mother and on the developing fetus and the baby when it's born. And it, if informed consent on that issue was done properly, then all young women who are considering going on an antidepressant need to be taken through all these pregnancy-related potential complications, as well as all the other side effects of antidepressants. And I actually think this is really, really important. I think it's a huge issue, because I think there is quite a lot of evidence out there that antidepressants can be harmful in various different ways. And of course, if lots of young people are going on antidepressants when they're young, they may have been on antidepressants for, for quite a long time before they get pregnant. And then even if they want to come off them, they may struggle to do so because by that time they'll be physically dependent and may have a problem with withdrawal. So it's really important that people are informed about all the potential risks when they start on an antidepressant, including, for women in particular, the risks associated with pregnancy and childbirth, and child development.
It's something that we wish was at the heart of all conversations, because it's important, and it immediately poses questions of where does this information come from? So queries ourselves as practitioners. I need to find out, have a good answer for my clients about why this is the case, where do we know that from, and so on. So I think it's always something that's important, but it's hard to do well, and it takes time, but that's the point.
It's hard to do well, and maybe just to mention, so it's also hard to do because there are institutions that are pushing back on it. So, for example, after that FDA panel meeting, there have been statements put out by various psychiatric organizations and other organizations, saying basically don't take any notice, antidepressants aren't that dangerous in pregnancy, this is scaremongering. And that's intensely depressing when you're trying to enable people to make informed decisions, but actually there are institutions that don't want people to be properly informed because there seems to be so much invested in people having a positive view of antidepressants. And a lot of psychiatrists seem to be very scared at the idea that these drugs might have, get a bad reputation and people might not want to take them quite so often. Quite why antidepressants in particular seem to be so important to psychiatrists, I think is an interesting question, because benzodiazepines, certainly in the UK, are much less favourably presented, and I think doctors generally appreciate that they have limited benefits and lots of risks involved in their use, and their use has come down quite considerably over the last few decades. But there hasn't been the same rethinking or reevaluation of antidepressants at all.
Well, I think there is a bit of from a human perspective, a threat response that I certainly feel it. I feel like, even though trying to delicately and respectfully have these types of conversation, try and learn, try and be curious, not just go, burn everything down, let's go against the grain or sort of nonsense. I want to know what's professionally right. I'm trying to seek the truth, right? And at the same time, I'm compelled, to this sort of threat response of saying, what can I say? What can't I say? Will I be attacked? Let me run the disclaimer now. I'm not a medical professional. I'm not giving any advice about whether someone should take medication or not. I'm simply interviewing, Dr. Joanna Moncrieff here, who has a wealth of knowledge and research and the like. But I'm terrified. And this is part of the problem. It's like you can't ask a question, or else you're being controversial, or you are saying something which you're not. But people can go out and make complaints and say, so you said this. No, I'm not saying that. Okay? Everyone can make their own decision, and so because of that, we tiptoe around the edges with fear, right? It's like, can I talk about this stuff, as though talking about it is wrong. But we're driven by that when there's a threat response, we say avoid, go away, shy away. It's not worth the hassle.
So in my book, I recount the story of a Polish journalist who did a video about my work and some work of some other people who've been critical of the overuse of psychiatric drugs. Um, I watched the video. She did it with no, it was in Polish, I think, but she did it with English subtitles, and everything she said was very reasonable and backed up by evidence. She was really strongly attacked by the members of the Polish psychiatric establishment who threatened to take legal action against her. She was therefore abandoned, all the media sort of cancelled her, which was obviously her job. So that was difficult. She was getting threats on social media and hate mail, and at one point, was afraid to go out of her house. She went to see a lawyer who said that she would have a case of legal action against the psychiatrist. And she just thought, this is crazy. I don't want to be in this sort of situation. And she very magnanimously reached out to the psychiatrist, the leading psychiatrist who'd led this campaign against her, and asked if they could speak together and try and resolve it, amicably. And in the end, the psychiatrist admitted that there weren't any significant problems with the video, and she made some sort of trivial apology for misnaming something, and eventually was able to put the video back up. But it was all a very traumatizing experience for her, and just illustrates how the psychiatric establishment can behave when they are perceive that they're threatened. And obviously criticizing psychiatric drugs and antidepressants in particular seems to threaten the credibility of the psychiatric establishment. Even though I've been trying to argue that it shouldn't, that there are other ways to understand these drugs which actually imply having a much firmer knowledge of them, of their pharmacological properties, than we currently have. And that there are situations in which drug treatment of some sort, some sorts, maybe not antidepressants particularly, but other sorts of drugs can be useful. But nevertheless, I think the psychiatric establishment is wedded to this disease model, basically, and if you start to chip away at that, it feels threatened and will kick back.
Have you personally had any experiences like that yourself?
Well, there were a group of psychiatrists who attacked the Serotonin paper in what I would say was a concerted campaign to try and undermine the credibility of the paper and my credibility. They published a critique of it. Of course, it's fine to do a critique of it, but they made numerous inconsistent, trivial, and mostly inaccurate criticisms rather than any, genuine ones. And it seemed to me that their overall purpose was not so much criticizing the paper, because they didn't even really disagree with our conclusions. They just wanted to say, oh, but there is some evidence of links between serotonin and depression. Well, of course, I'd never denied that there was some evidence. There's just a lot of negative evidence as well. So I don't think they really aimed to have a sort of proper scientific debate. I think their intention was to dent the credibility of the paper, so that people would go on believing that there is some sort of that there are grounds to believe there is some sort of biological mechanism underpinning depression.
Joanna, where can people find out more? There's listeners who would like to continue this conversation. I know you've got numerous books, papers, lectures online and the like. But where could we start? What would you say for listeners? Where's a good place to begin?
So I've got a website, which is joannamoncrieff.com. I'll send you the link. So that's a good start, and I've summarized some of my papers on that website as well. And there are lots of papers that are free to download online as well, so you can Google them and come up with some of them. Some of them are also, most of them also should be available on my university website, which I'll also try and find the link for and send to you. And then my books, the most recent book is Chemically Imbalanced, The Making and Unmaking of the Serotonin Myth. And then there are other books such as A Straight Talking Introduction to Psychiatric Drugs, which was published in about 2020 and covers all sorts of psychiatric drugs. So not just antidepressants, but also antipsychotics and benzodiazepines and stimulants, mood stabilizers. And another couple of books. I wrote a book on antipsychotics called The Bitterest Pills. And I'm on X as well. People can follow me on X and B-Sky.
And if I can also say a personal recommendation to a lecture that you did at UNE about the myth around the chemical imbalance, something like that. You won't miss it. It's been widely watched, and it was a great introduction, at least for me, many years ago.
Right.
Stimulated this seeking of the evidence, the truth, trying to understand it so that we can be better clinicians for our clients. So we can support humans to live in a more productive way, and that informed consent, understanding, and doing it in a transparent way, not saying, antidepressants should be removed, but having a conversation about what is the evidence. We're not saying for nor against, good nor bad. But if this is the information that's available, people can make their own conclusions. And I'm not suggesting by any stretch of the imagination that there aren't stories of people who say, I've personally taken them, and for some people, so it's a great value. But we equally see others. And the idea around research is to try and be informed, guided, and from what we've discussed today, the principle of the disease model needs to be discussed, and from a foundationary point of view. And I think you really shed light on that and do it in such an elegant way. So I just wish I had another 6 to 10 hours with you to talk about all the other medications and your viewpoints and the research there as well. But thank you so much, Joanna, for all your work, for your contributions. I know that this isn't easy to discuss, although very important. And wishing you all the best with continuing to discuss this, without an agenda other than, what do I believe is the truth. I'm trying to find, information that resonates and is logical, without a bias, just trying to talk about what does the evidence, point towards. So thank you for all of your work, your efforts to date, and wishing you the best ongoing as well.
It's been a pleasure. I've really enjoyed talking.